Good afternoon. We will be discussing a very complex case of lower cervical and upper dorsal bony tumor, which presented to us with paraparesis. I would like to invite my resident, Dr. Sivaraman, to introduce the case.
Good evening, everyone. This 18-year-old male presented with the progressive weakness of bilateral lower limb since 3 months and bowel and bladder involvement since 1 month. And on past history, patient is a known case of pulmonary tuberculosis for which he was on anti-tubercular therapy since September 2021. On examination, general physical examination, patient was emaciated and higher mental function and cranial nerves were within normal limits, and motor, the bulk was decreased, and tone had grade 3 modified Ashworth grading. And the power in bilateral lower limbs are 0.5 across all joints in both lower limbs, and the sensor loss is at the level of D4 level, and bilateral lower limb knee jerk and ankle jerk were exaggerated with clonus, and patient had bilateral plantar extensor responses, and with ankle and patellar clonus positive, features which are suggestive of myelopathy. Now I would like to invite Dr. Sharik from neuroradiology to discuss the imaging of this patient.
Thank you, Dr. Siva. Good afternoon, everyone. So these are the snapshots from the image the patient was carrying. This is a non-contrast MRI. These are the sagittal T2 weighted images. What we are seeing is a lesion that's arising from the D1 vertebral body. It's a T2 hyperintense lesion with a prevertebral soft tissue component. There is some soft tissue seen in the intraspinal canal. So these are the axial images. The lesion is seen arising from the vertebral body, the bilateral pedicles and the lamina. So the posterior elements are involved, and we can see a large hyperintense heterogeneous soft tissue component in the prevertebral space and some soft tissue component in the epidural space. So the lesion here, what we can see is there are some linear fine T2 lines. These are the fluid levels. We'll appreciate these in subsequent better quality images. So after 1 month, the patient had a repeat MRI. This is the contrast enhanced MRI. But we are seeing the lesion has increased in size. This is the lesion involving the vertebral body entering into the spinal canal. And note the characteristics appearing of the intervertebral disc. The enhancement is avidly enhancing, and there is a large prevertebral soft tissue component. The lesion has increased in size, and you can see a large bulk of the tumor that is now this component into the epidural space, and that is compressing the spinal cord from all sides. So this is the CT scan of the patient. You are seeing on sagittal images the lesion shows a lytic appearance. There's a lot of destruction, lytic areas, and a lot of this expansile bony lesion showing this fine axial type of cortex. Note the lytic lesions involving the posterior elements as well. So the imaging features would suggest in this case the primary bone tumor, and the imaging features are favoring aneurysmal bone cysts because of this expansile fine thin cortex, the T2 hyperintensity and the fluid levels. Other differentials would include the pathologies which have secondary ABC transformation like the giant cell tumor and osteoblastoma.
So this was indeed a very complex case. Actually, I would like to add something here, that this patient was previously admitted to the Department of Medicine, and he was a known case of pulmonary TB. So everybody thought that the lesion might be tuberculosis, but the points against TB was that the disc was preserved, and there was lytic expansile lesion of the bone. So this was the chronological sequence of interventions that we planned. The procedures that were highlighted in green were the initial procedures that we thought of, that they will be sufficient enough for the patient. So for the first surgery was planned was was basically a posterior approach and decompression of the lesion by doing laminectomy of D1 to D3 and putting pedicle screws in C6 and C7 and D4 and D5. After decompression, adequate thecal site decompression was achieved, and a solid implant construct was completed using rods and transverse connectors. So this was the post-op imaging, and we can see that there is some decompression posteriorly, and there is an implant construct at the posterior margin. The patient was actually planned for a second stage surgery from anterior approach, but because of surge in the cases of COVID, he was discharged. Now I would like to invite histopathologist sir.
So good afternoon, everyone. We received a bony tissue from for this patient, and section examined show woven bone formation. Here we can appreciate the woven bony trabeculae with large areas of hemorrhage, and there was monomorphic spindle-shaped cells in between the trabeculae, and some osteoclasts like giant cells were also seen. So with this morphology, the large areas of hemorrhage, monomorphic spindle-shaped cells, and the osteoclast like giant cells, the possibility of giant cell tumor like osteoclastoma and aneurysmal bone cyst was considered. So we performed H3F3 to rule out giant cell tumor, and it was negative. So with this morphology, we given a diagnosis of aneurysmal bone cyst. We received another specimen of the same, and it was a large specimen, and here we can appreciate the woven bony trabeculae with these trabeculae were lined by plump osteoblast like cells, and there was large areas of hemorrhage, multiple osteoclast like giant cells, monomorphic spindle shaped cells, and the lymph node was also sent, which shows reactive lymphoid hyperplasia, and it was free of tumor. So we again perform H3F3A to rule out giant cell tumor of the bone, and it was negative. So it was given as aneurysmal bone cyst recurrence. Again, we had received a specimen, showed the same morphology. So given the same diagnosis, that is aneurysmal bone cyst with recurrence. Thank you.
The patient presented 6 months after the initial surgery, whereby the patient developed a complete loss of sensation below the nipple area since 3 months, and difficulty in breathing with upper back ache since 2 months, and urinary retention and constipation since 2 months. On examination, the patient had paraplegia with grade 3 spasticity, and reflexes were exaggerated in bilateral lower limbs with bilateral ankle fluids. I would like to call Dr. Sarik for
So by now the lesion has significantly increased in size. You can see the lesion is now involving multi-level vertebral bodies, and there is the sparing of the intervertebral discs, and there's a large the prevertebral soft tissue component that has again increased in size, and you can see the compression on this structure. This is the esophagus, and anteriorly is the trachea. There is significant near total collapse of the tracheal lumen. So here again we can see this large soft tissue component, and there is this component which is entering into the spinal canal, and this is the spinal cord, this structure, and you can see how much compressed it is, and it is involving now almost all the elements, the anterior, the vertebral body, and the posterior elements. And here we can see this the fluid levels. These are the better quality images. So these are the fluid levels that are quite characteristic of this aneurysmal bone cyst. So diagnostic angio was also done to look for the vascularity and any or any this possibility of pre-op embolization. These are the angiograms of the bilateral subclavian arteries, and we can see these are the thyrocervical tracts, small branches that are supplying this region. No definite feeders were seen, no large feeder, and this is the intercostal bronchial trunk. and this is the bronchial artery, the right bronchial artery, and this is the intercostal feeder. There are multiple small feeders that are supplying this tumor.
So as we can see that the tumor grew at least 4 times its initial size, and it was a surprise as well as a challenge for us. So the real challenges for this patient was its size, that required an extensive surgical approach. And the second thing that was very important, that is always there with the large tumors like this, is vascularity, that we tried to tackle with an endoscopic tumor embolization, but it was not feasible. After that, the other thing that was important was circumferential encasement of the thecal sac. That was the cause of paraplegia, and there was a significant doubt that the tumor might have invaded the aerodigestive tract as well as the pleura. So he was actually planned for endovascular embolization, and he was taken up for embolization. But the thing, there was a surprise thing that happened when the patient was attempted GA and intubation. For that, I invite Professor Keshav Goel to elaborate.
Very good afternoon all. So up till now everything was going fine. The patient was a lean thin guy, 18 years, and there was no neck swelling. Otherwise the patient was completely fine. The breathing difficulty was found later on actually. It was not, he was sitting quietly and there was no breathing difficulty which was told. And as such the patient was taken on because the primary PSC was not done, this patient was taken for general anesthesia. As soon as we intubated, so we intubated this patient with a normal ventilation, normal mask ventilation, CL grade 1, everything was fine. As soon as we intubated, we could not negotiate the tube beyond 20 centimeter mark. There was a rise in the pressures. We could not, the tidal delivery was limited, capnograph started rising. And then there was nothing, the patient was, the desaturation was also occurring. So point of resistance at the suprasternal notch, possible tracheal obstruction from underlying tumor was thought. So initially the patient was all fine, but after general anesthesia, the patient had these much problems. What to do? So we went back and we tried to reverse the patient and extubate. But after extubation, the patient had again difficulty in extubation. We took him to the ICU, put on NIV, HFNC, tried supportive treatment, ETCU was coming a little down, but yet not good. Now what all other options we retrospectively analyzed, and there was a almost basically there was an obstruction in the tracheal which was being done by the aneurysmal bone tumor. Here we can see almost there is a almost chink, the kissing trachea is seen here, and it is below behind the sternum, manubrium sterni. So it is the tracheal inlet, so just above the carina. So here the tracheal, so basically what options we had, we tried for elective tracheostomy, that was not feasible. Tried for intratracheal stenting, is that feasible? Again we need to intubate that, then only it was possible. And we discussed with CTBS surgeon also for thoracotomy, if they could go ahead with the sternotomy and if they can relieve us. No. So the last option was, the patient was in the spontaneous ventilation, he was breathing well, so let us try and take help of the spontaneous breathing, and those tracheal muscles will help us give some space, and we'll take help of the awake fiber optic, its flexibility and maneuverability, that will help us in bypassing that constriction that we are seeing. We took a high risk consent in sitting position because he was comfortable in the sitting position, not in the supine or in the lateral. His breathing was deteriorating. From the right side, we started and monitor on the head end. Airway was prepared adequately with the local anesthesia, gargles, and IM glycopyrrolate. We went ahead, and then narrowing was seen in the lower tracheal segment just of the carina. So we had to bypass that, and we went below in the right primary bronchus. We had to intubate till 26 centimeter. So as the patient was spontaneously breathing, we always kept him on spontaneously breathing. So bilateral air entry was equal, and thereafter the tracheal stenting was done, and then this patient was further taken up for surgery.
So it was a nightmare for the anesthetist at that time when he was taken for embolization, because they were clueless that what has happened. Ultimately, they reviewed the CT and got to know that what was happening. So this was the, after intubation, when the area was secured, he was sent to pulmonary medicine and tracheal stenting was done, so that we can have a separate, another layer of safety. Now coming to the surgical management, the objective of surgical management was to relieve the airway compression. The first and the foremost thing was that. After that, spinal cord compression, and third objective was to achieve at least a complete macroscopic tumor excision, and the fourth objective was to reconstruct the spinal cord, because we had a defect that was extending right from C6 to D4. That was quite a long segment. Just for the sake of comparison, this was the image on the left side was the first radiology available. You can see that only D2 was collapsed and there was a very small lesion. And image on the right shows the latest imaging after this, just prior to the second stage of surgery. It involved right from C6 to D4 with a lot of spinal cord compression and mediastinal component. So this was the second surgery that was planned with ENT and surgical oncology. We did an anterior transcervical, transthoracic inlet approach. There was a we just went and identified the tracheoesophageal groove, and the vagus nerve was identified and preserved. Tumor was quite large actually, and it pushed the esophagus and the trachea anteriorly, and we could identify we could do central debulking of the tumor. That was actually, the tumor was quite surgeon friendly because the capsule was tough and it could be easily dissected out of the viscera, and the core was soft. It could be taken easily out. So significant tumor decompression was done and hemostasis was achieved, because the primary objective of decompression of trachea and decompression of spinal canal was achieved in this surgery, and patient had a blood loss of around 800 ml. That was quite a lot for that emaciated patient. After that, there was we could do at least 60-70% tumor decompression, and the surgery was staged. This was the imaging after the first surgery. We can see that the tracheal shift has reduced. The trachea has opened up. There is a metallic stent. You can see the outline, and this is the exhale section that shows these air shadow. That means we have decompressed at least the lateral gutters of the spinal cord. After that, we undertook a third stage surgery 4 days after the second stage. In that, we collaborated with ENT and CTVS. The previous incision was extended till xiphoid process, and midline complete sternostomy was done, and we could achieve a wide tumor exposure. The inferior limit of the exposure was aortic arch and innominate veins. We could see the residual tumor that was extending from C6 to D4 in the paramedian fashion. It was extending till the apex of the lungs. We could easily dissect out the tumor from the pleura, from the trachea, and the thecal sac. There was a small rent over right side of the pleura that for which we did a primary repair, and the final objective was achieved by placing a mesh cage that was quite long, around 9 centimeters, and a plate. So we did anterior fixation extending from C6 to D5, and this is the post-operative radiology showing the mesh cage, plate, and the posterior screw rod fixation. For the rest of the post-operative course, Dr. Shivraman, please.
Post-operatively, the tracheal stent was removed and the patient underwent elective tracheostomy. But the patient didn't have any improvement in the neurological status. Gradually, the patient was weaned off from ventilator and he was tolerating on room air. The patient was discharged on post-operative day 35 with a tracheostomy in situ and on Foley's catheterization. And the patient was planned for follow-up MRI after 1 month, which initially showed a small residual lesion at D2, D3 transverse process level. And the patient was referred for adjuvant radiotherapy, but patient was lost to follow-up. The patient presented to us again on September 2022 with a grade 3 bilateral gluteal and sacral bed sore and with urosepsis. And on evaluation, the patient had cystitis with bladder colonization. So the patient was started on back therapy for the bed sore and was started on IV antibiotics based on the culture sensitivity of the urine cultures. This slide shows the progression of the recurrent lesion which is seen in the D4 transverse process level. The initial MRI which was seen in May 2022, there is a gross increase in lesion on the post repeat MRI in October. The first image shows the comparative T2 sequences and this shows the T1 contrast lesion. This image shows the sagittal sequence whereby we could achieve significant decompression of the spine, whereby the anterior and posterior thecal sac is relieved of the compression and the cord is has no signal changes, and this same T2 axial sections and contrast sections. This image shows the postoperative CT cervico-dorsal spine, which shows the anterior mesh cage with anterior cervical plating and the posterior fixation of the C4, C5 and the dorsal fixation. After starting IV antibiotics, the patient was initially improving from the sepsis and he was afebrile. But the patient suddenly developed torrential tracheal bleed due to prolonged tracheostomy in situ. Suspected innominate artery fistula was suspected, but the patient succumbed to the hemorrhagic shock and he could not be revived. And the autopsy was refused by the relatives. So my discussion is on aneurysmal bone cyst of the spine. It has a prevalence of 1.4 cases per 1 lakh individuals in the population, and it constitutes 1% of all bony tumors, and it's most commonly seen in the first 2 decades, and it has some slight female predominance in contrast to our case. The management, however, surgical resection is the treatment of choice. It cannot be achieved by everyone, and various options are available. The intralesional curettage and bone grafting. Complete excision is always the treatment of choice. Arterial embolization, if feasible and if can be done, it decreases the intraoperative blood loss and thereby prevents morbidity of the patient. And radiation for in the postoperative adjuvant therapy and intralesional injections with calcitonin steroids or combinations have been described in literature. If there is significant cord compression, the best treatment is for decompression of the thecal sac, which we could achieve in the initial surgery, which was our primary principle in the first surgery. Role of denosumab in a comparative literature review, they have it's actually not FDA approved for aneurysmal bone cyst, but in case of locally advanced or inoperable or recurrent lesions, denosumab has a role and it has been used in literature. The main drawback of aneurysmal bone cyst is the recurrence of lesion. Actually, it's mainly due to the residual lesion which progresses, which is initially left behind by incomplete excision of the lesion. And the rate of local recurrence or the rate of progression of residual lesion is directly proportional to the extent of resection. And incomplete excision has a higher recurrence rate, and however, the complete excision has a high cure rate. So incomplete excisions, they have at least 50 to 60% of disease progression, but 90% of the recurrence occurs within 6 to 12 months following incomplete excision. So these patients need a extensive regular follow-up. As seen in our patient, he had a more increased recurrence in within 6 months. So the patient should be advised for regular follow-up if they undergo incomplete excision. And recurrence is unusual after 2 years and it's extremely rare after 4 years. I will like to invite Professor Pankaj.
So this was a very complex case, and in between it was that whether we should go in when the tumor has increased a lot, but we thought we should go in and we should give a chance to the patient. So by combined approach for neuroradiology, anesthesia, oncosurgery, CTVS and ENT, by the help of all these departments, we went in and we were able to do a good decompression. And the first time, this was the largest plate which was available, which we have used, is 10 centimeter. First time we have used this. This is the longest plate which is available. And this is a very long fixation, and we were able to achieve it, but destiny was decided and there was a torrential bleed from tracheostomy and the patient died. Any questions? And the patient also didn't improve, his paraplegia didn't improve even after such good decompression. You were able to do a good decompression, cord was very well decompressed, but the patient's power in lower limb didn't improve. This was a very big, this was 10 centimeters. This is the longest available plate. We were able to put it successfully. Okay, thank you.